but once again, the differences were not significant. In summary, there is a trend for increasing interest in PCL sacrificing implants due to the inability of posterior stabilized implants to recreate normal knee kinematics. Although some positive results have been shown in the literature with congruent designs, the evidence has yet to overwhelmingly point to one design as being superior to the other. Thank you.
Thank you very much, Sebastian. That was a very great overview of the three different systems that can be used and their advantages and disadvantages and how the trends should use. Let me ask you, you are mostly what kind of user for knee arthroplasty?
So we are a large center in Toronto, do now about 2,000 total knees a year. And we have it so that everything's very standardized. So all the surgeons use the same implant, and that is a posterior stabilized implant. I think with the advent of robotics, we may be looking at exploring a medial congruent design. But for the time being, my experience has been with the posterior stabilized.
You mentioned a very important point because you said in a high volume center you want reproducible results, and I think you need a system that works for everybody, because if you become overwhelmed with too much difference, you increase the complications risk. Aren't what you're using?
Yeah, I'm coming actually from medial pivot, but now using more CR. I try to stay with CR and intraoperatively, if I see that the PCL is not that stable, I can change for PS. So that's my way actually. So what is your way, Michael? What are you doing?
I'm coming from a very different setting where like Sebastian, that as a high volume center, it's important for us to have reproducibility, be able to have a consistent flow, and we use mostly just PS knees. But we have the CR knee if needed on shelf, and some of our surgeons will use a CR knee for primary total.